Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and I want to talk about some what I guess you could call radiculopathies, because that's the pain, that's the symptom. Nerve issues going to the hand. Not always the full pathway. In fact, the two people I was going to tell you about is really only impacting their forearm or fingers. So you could say it looks like a radiculopathy because it's usually happening to them in sleeping positions. But I want to tell you, all right, so I'm going to tell you about the first one. I'm going to tell you is I saw this patient for the first time this week, and over the past 4 months, his symptoms have gotten worse to the point that now it interferes with sleep, and he can only sleep a couple hours at a time before his hand is tingling. So he came in and explained, he showed me where the tingle is. It's like the back of the hand. He feels it going over basically the back of the hand, the index finger, the thumb, and the forearm, the lower third, the forearm. So I'm thinking superficial radial nerve. And I asked him I did a little Tinel's tapping about 6-7 centimeters up from the wrist, like the styloid of the radius area, and it does tingle there. And then he also says it's irritated when he uses his electric razor because the vibration irritates it, and he can't do it. He has to use the left hand instead of his dominant hand. And I also asked him if he's in bed, it's easier if the palms are turned inward toward him as opposed to flat on the bed, because that's usually when the compression of the superficial radial nerve is worse. So if the palms are flat on the bed, he'll have more symptoms than if he turns the palms inward. And he said, yeah, absolutely. That's what I've had to do. I had to basically like hold a pillow and keep my arm aligned in a certain way to not have the tingling and numbness, and it's uncomfortable enough that he can't sleep. So that's for the past 2 weeks. He was referred by someone else who'd had some hand numbness that I had resolved. So we did the ruse test to see if there was like neurogenic thoracic outlet syndrome, and he was tingling within 30 seconds. He works out a lot. He does a lot of CrossFit. His upper trapezius is very tight, and it does have trigger points. We did length testing for his pectoralis, major clavicular and sternal heads, and they were both shorter on the affected side, which was the right side. We did a lat length test, arms overhead, flat on his back. The right side was shorter than the left. Lying flat on the table, it was noticeable that his pec minor was slightly shorter on the right. So his acromion was a little higher off the table on the right side than the left. And then palpating that common tendon at the coracoid process, you could feel the tonicity of the pectoralis minor. And So all those things were leading to seeing a double crush scenario. The right scalene was a little tighter than the left, though I did not elicit any nerve symptoms by pressing on the medial scalene or in the front of the medial scalene. So it was probably just partially just decreasing the space of the thoracic outlet, but probably not a compression of the brachial plexus from the medial scalene. Um, and then what else did we do? So then I decided, okay, we're gonna treat this as a well. Okay, so I did the Tonells. I told you that. Um, so I know that I'm going to treat the muscles that can compress where the superficial radial nerve comes out, which is going to be primarily brachioradialis and the extensor carpi radialis longus. That nerve comes out of those two muscles right along the radial edge of the radius, and that's why the arm position change can compress it. It's like a little tube or tunnel of fascia that nerve comes out. It's a sensory only nerve. So so I knew I would be treating that last because that's probably the easiest of all of these things. I started with him on his lying on his left side to treat his right side. So we treated serratus anterior, latissimus dorsi with motor points. I treated the right middle scalene, the right levator scapulae. Then I had him on his back, and I treated his pec major, sternal, and clavicular heads. I treated pectoralis minor. He had already had a history of some anterior shoulder pain and had noticeable soreness in the coracobrachialis. So I treated that more for his history of shoulder pain than for the internal rotation of shoulder. However, it's not a bad option to consider because of its connection to the coracoid process of the scapula and the humerus. So it can contribute to some internal rotation, though it's probably not primary for a neurogenic thoracic outlet syndrome. Whereas the pec major can, because it runs right across that bundle, that nerve, that the nerves and artery and vein area. So that's important. The lat also increases the internal rotation, affects the upper cross syndrome, and can impact the thoracic outlet. The latissimus dorsi also internally rotates the humerus, affecting the posture and then affecting the thoracic outlet. And also the fascia of the lat can be lifting the ribs a bit, which will decrease the space between the clavicle and the first rib, which is the thoracic outlet. So that's my go-to for the neurogenic thoracic outlet. However, the trigger points in the upper trapezius could be also affecting the clavicle. So then I did dry needling of the upper trapezius. Before treating his forearm, I had him do the ruse test, and it was negative. We waited about a minute with the ruse test. It had tested positive within 10, 15 seconds originally. And we got to a minute, and I said, okay, I already know I'm going to be treating the forearm, so I'm not that worried at this point that the thoracic outlet is still involved as a double crush. Let's go for the real entrapment zones. So I did treat the brachioradialis and the extensor carpi radialis longus. I used more than one needle in the extensor carpi radialis longus because I could feel a really dense fibrotic feel to it, and I wanted to just make sure I got more than one needle into the muscle to really free it up. So we did that brachioradialis, and and then we could not then reproduce the tingle. Now, being a CrossFitter, I had noticed that his lat on the left and his pecs on the left were also a little shorter than optimal. So I said, if you're not opposed, let's fix your left side too, so that your posture is good And so that when you do CrossFit, you feel like both sides are powerful and not just the right side that I just treated. So I treated serratus anterior, latissimus dorsi, um, and in the process, he said, "Oh, he was lying on his right side, which is the affected side." He said, "Oh, I am feeling some tingling in the palm of my hand right now, just at the thumb and index finger on the palm." And he said, "That's different because I don't usually feel it there." So then that's sort of like a little puzzle. And I'm thinking, well, he is lying on his right side. It is the thoracic outlet. Maybe it's a symptom that he didn't feel before because the other was more annoying. And then I thought, but what if it's something else? What if it's coming more from the infraspinatus? Maybe a trigger point in the infraspinatus is there, and it was the crying child that he couldn't hear, because the other was so loud. So I had him lie face down and I palpated the infraspinatus on the right side, and he had a lot of painful trigger points there. And this is probably why he had this right shoulder pain. I treated the coracobrachialis, but it's very likely that, and it had gotten much, much better. He was back to working out, and he still just had to avoid certain movements, wide presses, things like that. He'd adjusted his grip to avoid that shoulder pain. But my theory then was, okay, infraspinatus trigger points were causing his anterior shoulder pain as well. And this highly sensitized trigger point might be actually creating the paresthesia in the C6 dermatome. So I palpated, I did some ischemic compression to see if it would reproduce his symptoms, and he didn't really feel it. But I said, but do you agree that we need to treat this? Because if nothing else, is for your shoulder pain. But I'm going to say that if I get into the right part of this trigger point and then you feel it into the thumb and index finger, that this is what we're looking at. And sure enough, that's what we found. I did some dry needling of the infraspinatus trigger point, and he was feeling it going into that the inner eminence of the thumb and the index finger. So I think it was kind of a combo. What did I want to say about that? So interestingly, I was looking into why that happens, because the infraspinatus is nowhere near C5 and 6, but you get this paresthesia into the C6 dermatome of the hand. But if you look at the innervation of the infraspinatus, the suprascapular nerve, it does come from the C5-6 level. So what if that trigger point is sort of traveling up the suprascapular nerve into the C5-6 and then down the dermatome, the sensory part, and so then giving you a feedback that seems like it's in your hand and the thumb and index finger. So that's the theory. That's my theory. It's probably somebody smarter than me's theory, but I just haven't found it yet to prove it. So the other guy, and so the feedback I got from, he immediately posted a really nice review and then had told the person that had referred him, who was already a patient of mine for a similar radiculopathy, that he got instant relief and he felt really, really good. So the guy that referred him was in yesterday, and this was his second visit. So I heard from his wife, who came to see me after his first visit for something entirely different, that he had gotten relief, but then the symptoms came back. So I thought, based on what she said, that it was only better for a day. And then the tingling in his third and fourth finger came back. And that was really bothering him. He got symptoms lying on his side or on his back sometimes of tingling and numbness in the third and fourth finger on his affected side, which was his right side. Now, I had treated it similarly as thoracic outlet and pronator teres syndrome, which seemed relevant because of the sensitivity of his pronator teres. But it occurred to me that I have seen these radiculopathies created by lower trapezius trigger points. And I've mentioned that in other podcasts, but I had this theory with him because of how rock hard his trapezius muscle is on both sides, actually. And he's an ex-firefighter, and he loves to work out at the gym. So his upper, middle, and lower traps were just like a rock. And he did tell me that sometimes when the tingling is bad, his mid back on the right side is painful in that lower trap area. So, and when I palpated it, it was sensitized. So I dry needled his upper trap, middle trap, lower trap, and levator scap right where it comes off of the scalene. The scapula. And he said that felt amazing. Like the release of those muscles felt great. So I wasn't sure because we couldn't reproduce his numbness after the treatment because it wasn't easy to reproduce without him being in bed for like an hour or something. So we just had to hope. All right. So I saw him yesterday and I said, so I hear from your wife that you only got better for a little bit and then it came back. He said, oh, I was better for like 4 days, almost maybe 5 days. And then it came back. And then I said, oh, okay. So then I was on the right track and it just isn't released enough. So sure enough, his traps still had some density that I needed to dry needle. And after yesterday's session of dry needling, it felt like supple tissue the way it really should feel. I'm really feeling optimistic about this. And he really agreed that area in the lower trap when it would twitch during the dry needling, it felt like the area that would hurt at night when this was happening, when the tingling in the hand was happening. So I really think that was the case. And you'll see this on a lot of patients, by the way. They'll feel it. They'll feel a nerve going down their arm. Usually it's the radial nerve pathway that comes from a trigger point in the lower traps. So I was trying to figure out like why is that? Obviously the lower trap isn't really close to like C5, 6, 7, area. The middle trap, the upper traps go through that area. And I did think, well, maybe if there's a trigger point in the lower trap and it's taking pressure off of the trapezius in general, then maybe that does affect those segments. But I have a different theory now. And I don't know why I really didn't think about it before. But if you did think about it and you already knew this, okay, you can call me stupid. But a lot of this stuff I feel like I have to figure out on my own because nobody's telling me this stuff. I haven't found the podcast that I can listen to learn all the stuff that I'm having to figure out on my own. And if you guys have that podcast for me, please point me to it. Because as far as I know, there's nobody out there telling us these things. But here's my new theory, and I like my theory. When you think about neurogenic thoracic outlet, the common entrapments that you're going to see come from the scalenes, the middle and anterior scalenes, because the nerves come right between them. Usually middle scalene is to blame because it's the bigger, thick one. And when it gets hypertonic, it presses on the nerves. And the pectoralis minor. Those are the two primary, compressors of the brachial plexus, creating a neurogenic thoracic outlet syndrome. And of course, all those upper cross syndrome muscles are increasing the problem by decreasing space in the thoracic outlet. Now, Here's the thing. Pec minor is a scapular downward rotator, right? So is levator scapulae. And I never understood, and I've mentioned this before, why dry needling the levator scapulae would get rid of these nerve radiculopathy symptoms that would go into the hand. And then I never understood why the lower trapezius trigger points would get rid of these nerve symptoms that would go down the arm or into the hand. And I guess you're putting it together. You're like lining up the dots because I'm giving you the little clues here. The scapular downward rotators, when they have trigger points and they become inflexible, I believe are downwardly rotating the scapula in a way that decreases space in the thoracic outlet. I think that maybe pec minor is primary because it runs right over the nerves in the artery and vein. But when levator scapulae and lower trapezius are also hypertonic, contracted, have trigger points, they contribute to that downward rotation of the scapula and decrease space in the thoracic outlet. And I love my theory. And I hope somebody knows somebody who's already proven this. But it explains everything. Like, because those are the things that I observed and couldn't really put together. The levator scapulae, the lower trap, dry needling, and the upper trapezius, of course, would relieve these hand symptoms of tingling, numbness, often when working at a keyboard or driving, things like that, where the arms would go out front. That this is when they would get those symptoms, and of course, sleeping at night, their hand would go numb, and they get up and have to like shake and try to feel like they're getting blood flow back in and find a better position. And often there's piles of pillows involved with finding that right position. So I hope you like my theory, because I'm really hoping, and I haven't done any sort of AI assisted deep research yet, but I'm going to see if someone else has made this observation and can validate what I think is happening. And by the way, I wanted to tell you that I intentionally did not treat the cervical segments because I did not want to confuse myself or congratulate myself on a theory that was not correct. For instance, if I'm treating C5-6 in a treatment where I'm sure that it's a thoracic outlet syndrome, then someone else could say, well, no, you treated the segment that they're getting the tingling from, and you're actually resetting the segment at the myotome and dermatome that are affected. So I intentionally did not treat the segments on their first visit so that I could be sure that if my assessment is correct, that they got better and I'm right. And that's what happened in both cases. Now, will I eventually treat C5-6 as semispinalis capitis? Absolutely. I might treat it there. I might treat it up close to the rectus capitis posterior major. There's always a benefit to treating neck extensors that get tight, especially on athletes. But I intentionally left them out as to not incorrectly assume that I was right on my initial diagnosis of a thoracic outlet and compression in the forearm. So for both of these cases, I had not treated the segments. I did treat levator scapulae, and I did treat medial scalene. So I wanted to put that out there. So I hope you found those interesting. I find it interesting. I think, every week is a discovery in the world of undiagnosed and misdiagnosed pain and constant obsession with spinal segments as the only cause of nerve symptoms. So, and I have to thank, Dr. Andrea Trescott again, because she really has given me so many tools to help people in one treatment or two treatments with nerve symptoms. And I think I mentioned it before, but one of my patients came back and said, you saved me from surgery, from neck surgery. They were sure that I was going to have my neck fused because he was having tingling in the hand when he would drive. I told you this, but I'm just telling you again. And it was an infraspinatus trigger point. There's a whole episode about it, probably 2 years ago. But I just saw him recently, and he thanked me again for saving him from fusion surgery of his neck. And he doesn't even have any of those symptoms anymore. So, when it's needed, it's needed. And yes, if someone has muscular weakness, they probably should be seeing a surgeon because they could become debilitated. But when it's sensory, I say try everything you can to avoid surgery, because so often it does not require surgery, and surgeons do surgery. Acupuncturists do acupuncture. If you come to me, you're getting acupuncture. Go to them, you're going to get surgery. So, and apparently, I've had people when I told those stories, I had someone come at me at the comments section and say, "That's not possible." They would never do a surgery or recommend a surgery without the EMG findings that there was, weakness and that there was going to become debilitating. I said, listen, I trust my patient when he tells me what the doctor told him. I believe him. People don't know a lot about all the possible scenarios. They know what their doctor has done, and they know what their doctor told them after what they did. And he was told within like one consult that he needed surgery. So anyway, I thank you, Dr. Andrea Trescott, for your work, because it has exponentially helped so many people that I see. And I still highly recommend that you look into her books and her YouTube lectures that are out there for free, and do whatever you can to learn about peripheral neuropathies. Peripheral nerve entrapments, because they are a game changer when you can accurately diagnose and treat them for people who have been given no hope and just a higher dose of Lyrica or whatever, gabapentin or whatever pharmaceutical their doctor is recommending for them, because that's no way to live. They, most of the time those people are still suffering, and then they're on medical marijuana. And, anyone who's had chronic pain knows how it affects your relationships and the quality of life and just about everything. How do you even plan for the future when you feel like you're stuck in chronic pain? Can you imagine how that defeats your hope for doing some major wonderful thing in your life, because you just want to be able to get out of bed in the morning, and that's your first task, and it's not easy. So like when you can help someone like that to not be in pain, it's a complete game changer. So I really recommend you learn about peripheral nerve entrapments. I just put a course online. The newest one has the most peripheral nerve entrapments that I've ever covered. Okay, so you'll see it's called "Unlock the Mystery of Chronic Pain." It's the newest one. There's one right before it that also is Yonda's approach as a guide for treating pain and peripheral nerve entrapments. That one does have a lot of good stuff in it, But the most recent one, if you're interested in learning peripheral nerve entrapments, this is the one that covers a ton of the most common peripheral nerve entrapments with demos of live people with many of the symptoms that I was teaching. And you get to see the good result at the end of the demo. So it's many hours of lecture and demo. And if you're interested and you don't feel like reading the book, see the movie. Like go on Podia and get this course. I'll put the July discount in the info in this podcast, because until the end of July, I'm giving $100 off for that. Okay, so thanks for listening, and I will talk to you soon.